Good afternoon, everyone. iTech India welcomes all the participants for today's regional distance learning seminar session. Today's topic is HIV and OI, skin and mucous membranes, and the speaker is Dr. Satyendra Kumar Singh. Dr. Satyendra Kumar Singh is a professor and head, Department of Dermatology and Venerology at the Institute of Medical Sciences, Banaras Hindu University, Varanasi. He is also the in charge of the STD clinic. He has multiple paper publications to his credit. We welcome you, sir, for today's session and request you to start the session. Dr. Satyendra, sir?
Yes.
Yes, sir, you can start the session.
Okay. Good afternoon, everybody. It is not running.
So I will change it from my end. Please say
Okay,
next
okay.
when you want to move to the next
Okay,
slide.
next.
Right?
Next slide, please.
Right, sir.
In this session, we'll discuss different type of mucocutaneous manifestation in HIV/AIDS. Among these, we'll discuss the different type of infectious conditions, inflammatory conditions, and some cutaneous malignancies and miscellaneous conditions. Next. More than 90% of patients living with HIV develop skin and or mucous membrane lesions in their entire course of the HIV infections. The prevalence of skin manifestation in children living with HIV ranges from 36% to 52%. Identification of certain skin condition can predict the presence of HIV because some dermatological conditions are highly indicative for HIV, like giant bullosum contagiosum and chronic herpetic ulcer, and there are so many others. If any skin condition which is persisting, recurring, chronic, severe, resistance to treatment, and atypical lesions, then one should suspect for HIV and AIDS. Next slide, please. This is the spectrum of dermatological manifestation according to the CD4 cell count. In these slides, you can see the first cutaneous manifestation occur when there is seroconversion, that is the primary HIV disease, in which even after the 2 to 4 weeks of the acquiring HIV infections, patient develop exanthem maculopapular rash, and after that, when CD4 cell counts falls below 200 cells per microliter, then the specific condition arises. So you can see the common condition like tinea, psoriasis, which occur when the CD4 cell count is more than 500, and when the CD4 cell count falls below 200, then the patient develop oral candidiasis, hairy leukoplakia, Kaposi sarcoma, Norwegian scabies, and some others are dermatological conditions. Next. Infective conditions include the bacterial infections, viral infections, fungal and parasitic infections. We'll discuss one by one. Then inflammatory conditions, cutaneous malignancy, and the miscellaneous. Next. Bacterial infections, fungal infections are also very common in patients with the HIV and AIDS. The most common bacterial infections are folliculitis, furuncle, ecthyma, deep bacterial infections, abscess, and impetigo. Bacillary angiomatosis, which is not commonly found in non-HIV patients, which is not found in the general populations, but it is mainly found in the HIV positive patient. Syphilis is one of the very common STI, which has got some dermatological manifestations. Cutaneous tuberculosis, again, it is found in the HIV cases, and diseases caused by another atypical microbacteria. Among fungal, the common fungal infections are dermatophytosis, which is the very commonly found in even non-HIV cases. But among these, the last three penicillosis, cryptococcosis, and histoplasmosis are usually found in immunocompromised patients. We'll discuss one by one. Next. Viral infections. Viral infections are also very common even in the non-HIV cases, but there are some viral infections which are highly indicative for HIV/AIDS, and that is oral hairy leukoplakia and giant molluscum contagiosum. But other viral infections like herpes zoster, herpes simplex, and the wart are also found very commonly. Among the arthropod infections, we found scabies, leishmaniasis, and Demodex folliculitis. Next. Inflammatory condition includes the xerosis and ichthyosis. This is the most common dermatological inflammatory condition found in the HIV/AIDS. Then psoriasis, seborrheic dermatitis, Rhesus syndrome or active arthritis, eosinophilic folliculitis, and atopic dermatitis. Among these, only the eosinophilic folliculitis is held highly specific to HIV/AIDS, and all other dermatological inflammatory conditions are also found in the non-HIV cases. But in the patients with the HIV, the severity will be very high, and the patient is usually resistant to the recommended treatment. Next. Cutaneous malignancy, most common malignancy found in our setup is non-Hodgkin's lymphoma and Kaposi sarcoma. Kaposi sarcoma is very rare in our country. And the other miscellaneous condition is acute seroconversions, which occurs after the 2 to 4 weeks of the acquiring HIV infections. Drug reaction again is very common in patient with HIV. Drug reactions are very severe, like the Stevens-Johnson syndrome, toxic epidermal necrolysis, and the psoriatic papular eruption is also very common in our setup because it is mainly due to the insect bite reactions, and it is found in advanced HIV cases. Next. So we'll discuss the bacterial infections, and the most common bacterial infection in HIV/AIDS is Staphylococcus aureus, and sometimes streptococcal infections. Next. These are the different type of the bacterial infection, which is mainly caused by the Staphylococcus aureus. There are some photographs in which you can see the folliculitis. First photograph is folliculitis, in which we can see the multiple tiny papules and pustules in this pubic area. This is the very superficial bacterial infections, mainly caused by Staph aureus. Another one is the ecthyma. This is the deep bacterial infections. It is mainly caused by Pseudomonas, but sometimes even the Staph aureus can cause. And the third photograph is of the non-bullous impetigo. It is mainly caused by Staph aureus in 90% cases. In some cases, 10% cases, even the Streptococcus can cause this type of lesions. Next. Skin manifestation, bullous impetigo. There are two types of impetigo: bullous impetigo and non-bullous impetigo. In bullous impetigo, one patient will develop the superficial blister, which is rapidly broken down and form the erosions. That may be polycyclic. And the most common sites, although it is written in the trunk and down, but the most common site is on the face. And management is topical cleaning and topical antibiotic. But in severe cases, patient required antibiotic, systemic antibiotic in the form of aminopenicillins, cephalosporin, fluoxetine, or erythromycin. If erythromycin is effective, and dose is 40 mg per kg per day, 4 times a day for 5 days. Next. Another Staphylococcus aureus infection is pyomyositis and the skin abscess. These are the deeper infections. And the pus collection, there will be pus collection below the skin or sometimes in the muscles. Initially, follicular lesions extend more deeply, forming abscesses, making the affected area fluctuant and warm. The area will be fluctuant and warm and painful also. And the management is surgical drainage and care of the lesions. And we have to give antibiotic. Ideally, one should go for the culture and sensitivity. And after taking the pus for the culture and sensitivity, one can start cephalosporin, fluoxetine orally for at least 10 days. Sometimes patient may require fluoxetine IV 1 to 2 gram 4 times a day for 10 days. In some rare cases, vancomycin is needed. But if there is no response with this drug, one should go for the other antibiotic depending upon the sensitivity testing. Next. Furunculosis and folliculitis. Furunculosis is nothing but the deeper infection of the Staph aureus. Skin sepsis around hair follicles, mainly the groin, axilla, sometimes trunk and face also. Carbuncle is cluster of furuncles with multiple opening because of invasion and necrosis of the subcutis. So these furuncles and the carbuncles are painful bacterial infections, and you will find the erythema around the lesions. This is very painful, and in management we have to use the systemic antibiotic. Most commonly used antibiotic is cephalosporin and cloxacillin, which are very effective, and they given in the as a QDS for 10 days. Next slide. Bacillary angiomatosis is very not so common in our setup, but it is not found in the non-HIV cases. It is mainly found in immunocompromised patient. It is caused by the two bacteria, Bartonella henseli and the Bartonella quintana. And this is in this type, the lesions are looking like the very vascular on the present side, the small red papules that gradually expand into large papular, nodular, pedunculated lesions. Lesions have a vascular appearance. There will be very red to purple color, and the surface is friable and bleeds easily. And this type of lesions also, in most of the cases, we found the depression in the center, just like the molluscum contagiosum. So this lesion may present at the molluscum contagiosum, but in molluscum contagiosum, there will be no redness or erythema, while in this condition, we'll find the erythema and redness. Systemic findings such as fever, night sweats, weight loss, anemia are common in the patients with bacillary angiomatosis. Visceral lesion may be as or more common than the cutaneous lesions. Sometimes involvement of the liver and spleen with or without skin lesion is the most diagnosed form of the visceral disease. Diagnosis is by special stain, silver impregnation, or by the electron microscopy. Erythromycin is the treatment of choice. Erythromycin is still very effective in the treatment of bacillary angiomatosis, but doxycycline may be used 100 milligram oral or intravenous for at least for more than 3 months. So, but erythromycin is still very commonly used and the very effective drug. Next. Next slide. Here we see the two cases. These are the cases of the skin tuberculosis, mycobacterial diseases. In first case, in both the cases, we can see the condition scrofloderma. In scrofloderma, the primary lesions, primary infection is found in the lymph nodes or the bone. In this case, the lymph nodes are involved, and after getting the burst out, when they burst out, then the skin is involved. So this is basically involved the lymph node, and sometimes underlying the bone is involved, and after sometimes few months, years, it burst out and skin is also involved. You can see here the pus coming out from the discharging sinuses. So this is one of the forms. Next. Other skin tuberculosis has also been reported. Like the most common skin tuberculosis is the lupus vulgaris. Tuberculosis verrucosa cutis is also sometimes found. Mycobacterium avium intracellular commonly present as chronic sinuses over involved lymph nodes. That is also known as the scrofula, chronic ulceration, etc. Mycobacterium hemophilium rarely can present with the cutaneous abscesses or ulceration, and tenosynovitis or arthritis. All the mycobacterial diseases which involve the skin are highly sensitive to ATT, and they will find the dramatic response with the ATT. So ATT is given according to the national guidelines, and the skin tuberculosis is highly responsive to the ATT. Next slide, please. Syphilis is very well known STD all over the world. In syphilis, there are different stages of syphilis, like primary, secondary, latent, and tertiary syphilis. But mucocutaneous lesions are found mainly in the primary and secondary syphilis. In primary syphilis, we get the single, usually single, or sometimes 2 or 3 lesions, a painless, indurated genital ulcer with inguinal lymphadenopathy. We call it Sankar. But sometimes the genital ulcer may be painful in HIV positive patients. Generally, septic ulcer are not painful in non-HIV cases. But in HIV infected patients, this herpetic septic ulcer may be painful due to superinfection of Staph aureus. So painful genital ulcer does not rule out the syphilis. Pain may occur in the syphilitic ulcer also. In secondary syphilis, most common presentation is hyperpigmented, scaly, non-itchy macules on the palms and soles, along with the maculopapular eruption on the trunk. So in secondary syphilis, also we can find the skin rise, which mainly involves the palms and soles. And the treatment is benzathine penicillin G, 2.4 million units, IM single dose after hypersensitivity test, and the follow-up with the RPR test at 6 months until it is bound to be negative. Next. You can see here the single indurated ulcer on the dorsum of the penis. You can see the induration elevated margins. This ulcer will be very neat and clean. And the painless ulcers. So this is the primary syphilis, which we also call is chancre, syphilitic chancre. In second photograph, you can find the multiple hyperpigmented macules, which will be asymptomatic. There will be no any itching or pain, and the same type of lesions are seen in the soles. So hyperpigmented, scaly, non-itchy lesions are highly characteristic of secondary syphilis. So they are the most common presentation in our OPD. Next. Now we'll switch over to fungal infections. Next slide. Candidiasis. Candidiasis most common after tuberculosis. Candidiasis is very common fungal opportunistic infection found in HIV/AIDS patients. Candidiasis is very common. Candidiasis can involve the oral mucosa. It can involve the genital mucosa. Sometimes it can involve the waves, folds on the other parts of the body also. But most commonly, it involves the oral and genital mucosa. And you can see here in genital oral candidiasis, we can find a white membranous covering of the tongue that reveals the eroded surface on the rim. This is very characteristic feature of the oral candidiasis. Although there are any more other type of the oral candidiasis, but most commonly the pseudomembranous type, which is when we remove with the glass slice, then we will find the raw area, eroded surface on removal. It can also infect nails and tissue around the fingernail, which is known as peronachia, with tenderness, erythema, and bogginess of the proximal nail folds. Diagnosis is by potassium hydroxide TOH examination of the skull taken from the active burden or a satellite pustule. But clinically, one can easily diagnose oral candidiasis. Just a curdy deposits on the oral mucosa or genital mucosa. If you see curdy deposits, curd-like deposits, then you can suspect the oral candidiasis. So clinically, we can diagnose oral candidiasis, genital candidiasis very easily. And treatment is topical antifungal such as clotrimazole 1% cream, metoprolol 2% cream. Sometimes patient require the fluconazole 100 mg or 3 to 6 mg per kg per day in children, orally once per 10 days. But there are some cases of oral candidiasis or genital candidiasis which doesn't respond with this dosage. So those patients may require higher dosage of fluconazole per day. Like we can go up to 200 to 400 mg of fluconazole daily for 2 weeks. We call that condition as the FROG, fluconazole refractory oral candidiasis. So some patient may require the higher dosage of fluconazole also. So if any patient who does not respond with this fluconazole 100 mg daily dose, one should go for the 200 or 400 mg per day for 2 weeks. Next slide. Tinea infection is very common, and it is also found in the HIV positive patients also. But in children which are living with HIV, tinea capitis can present with the broken hair resulting in non-scarring alopecia. Sometimes it can present in HIV positive patients. We are seeing patients with the inflammatory lesions, boggy swelling on the scalp of a child, which is an inflammatory form of the tinea capitis. So we can also find the inflammatory type of tinea capitis on the scalp. And if you are seeing, because diagnosis is not so easy, so it is better to refer to a dermatologist. Next slide. Other fungal infections are Pityrosporum ovale and orbiculare, which is also known as the Malassezia furfur. This causes seborrheic dermatitis and pityriasis versicolor. So these are the causative mechanism. Colonization occur in the scalp, flexus, and the upper trunk, especially the chest, mid part of the chest, and the mid part of the upper part of the back, interscapular area. Diagnosis is clinical, confirmation by the QH examination of skin scraping. Treatment of this type of fungal infection, Pityrosporum oval and orbicular, is the selenium sulfide shampoo, or sometimes patient may require topical imidazole antifungal cream also. Oral etoconazole is rarely needed. All the patients responded with the topical treatment. We don't need to go for the. Next, please. Systemic and deep mycosis. These are the concern for the bacterial fungal infections, which includes the penicillosis, cryptococcosis, histoplasmosis, sporotrichosis, aspergillosis, candidiasis, coccidioidomycosis, and actinomycosis. Among these, penicillosis, which is also known as the tularomycosis, now penicillosis is known as the tularomycosis, penicillosis, cryptococcosis, and histoplasmosis. These three are typically found in patients living with the HIV/AIDS. Tularomycosis or penicillosis is mainly found in our northeast region, northeast region of the state, in which we find the central necrotic papules with umbilication appear on the face, trunk, and extremities, which occurring in the 40 to 20% of the patients, and these patients are mainly from the northeast states. Cryptococcal skin lesions. In cryptococcal infections, umbilicated skin lesions mimicking molluscum contagiosum is found, but these lesions are mainly found with the cryptococcal meningitis. It is very uncommon to have isolated cryptococcal skin lesions. This type of lesions mainly found with the cryptococcal meningitis because that is the more common than the cryptococcal skin lesions. Next slide, please. Here we can see the clinical photograph of these three common deep mycosis which is found in HIV/AIDS. First slide is of tularomycosis, in which we can see the face, we can see and find the patient is from the northeast state, that is the Manipur. Here we can see the hyperpigmented nodular lesion with central depression. This is very characteristic, just like the molluscum contagiosum lesions. Second slide is of cryptococcal skin lesions. You can see the multiple molluscum contagiosum like lesions, and patient is most probably is also having cryptococcal meningitis, seems to be unconscious. So skin lesions of cryptococcal infections mostly occur with the cryptococcal meningitis. This is here we can see the multiple papulonodular lesions of the histoplasmosis from the trunk. So these three conditions are found mainly in the HIV/AIDS patient or rather immunocompromised patient. And all these three conditions require systemic antifungal. The most commonly and effective drug for these three conditions are the itraconazole in higher dosing. Next slide. After fungal, we'll discuss the viral infections. Next slide. Human herpes virus is very characteristically involved in the HIV positive patients. It is mainly transmitted through the homosexual route. It is the very specific, any patient is having Kaposi sarcoma or human herpes virus infection in our country, so HIV is confirmed. So Kaposi sarcoma is highly indicative diagnostic of HIV/AIDS in our country. There are some countries in the East African countries where Kaposi sarcoma is endemic, and the patient there are this condition found even in the non-HIV cases. But in our country, it is always found in HIV positive patient. So if patient is having Kaposi sarcoma, it means patient is HIV positive. Skin lesion, most common site of the human herpes virus, it is the face in HIV positive patient. Face is the around the eyes, nose, and the oral mucosa, upper part of the mucosa, upper hard palate. Skin lesions start with non-tender, hyperpigmented or violaceous macular or nodular skin lesion. Initial skin lesions of the Kaposi sarcoma is just like the mosquito bite, are very small blunt trauma, bruises-like lesions, and later on these lesions develop into the hyperpigmented biliaceous and the nodular lesions. Oral lesions are also very common, which is seen as the purplish fleshy swelling on the roof of the mouth or gums. Sometimes lymphatic system is also involved, but lymph node enlargement in Kaposi sarcoma is not a bad prognostic sign. In fact, it is the good prognostic sign. So lymphatic system may be involved in Kaposi sarcoma. Sometimes GIT and the lungs are also involved in Kaposi sarcoma. Next slide, please. This is again the description of the Kaposi sarcoma, non-tender hyperpigmented biliaceous macular nodular lesions. Pulmonary, sometimes lungs may be involved, and penetration will be similar to pulmonary tuberculosis here, a PCP. And internal viscera may also be involved, especially the GIT, and the patient may present with the rectal bleeding or melena and some other non-specific GI symptom. If there is involvement of the lungs, patient may have shortness of breath or some other respiratory problems. A diagnosis is by cytologic and immunological markers as well as histology. Next. Here we can see the cutaneous Kaposi sarcoma. You can see at the purplish nodular lesions on the lower eyelid. This is the characteristic feature of the Kaposi sarcoma. Although nose is also very common sites for the Kaposi sarcoma. You can see here some nodular lesions on the soles. This type of lesions is found in Eastern African country, which are in the non-HIV cases, but sometimes even in HIV cases, we can find this type of lesion in the legs. Legs is the most common site of the endemic Kaposi sarcoma, which are found on the Western African country. In epidemic form of the Kaposi sarcoma, which is associated with HIV infection, face is the most common site. Next slide, please. Management of Kaposi sarcoma. All Kaposi sarcoma doesn't need treatment. Majority of the Kaposi sarcoma improve with start of the ART when the patient's immune system get improved, then the lesions will disappear. But some patient may require treatment. If patient is having the lesions on the face, which causing the cosmetic disfigurement, then the patient may require treatment. If lesions are around in the oral cavity interfering with the feeding or some respiratory problem, then patient require treatment. If visceral systems are involved like pulmonary or GIT, in those cases we have to give treatment. Sometimes skin lesions may be found around the knee joint. The lesions around the knee joints are very, very painful. So there are some different indications for the treatment. All Kaposi sarcoma lesions should not be treated because most of the lesions will disappear with the ART. So here is the chart we can see here, mild to moderate Kaposi sarcoma, which is localized skin lesions. There is no need of any specific treatment except the ART. Advanced Kaposi sarcoma lesions. Kaposi sarcoma lesions are highly sensitive to chemotherapy and radiotherapy. So these lesions are very, very sensitive to chemotherapy, and there will be drastic improvement with the chemotherapy and radiotherapy both. So these are the different type of the chemotherapy regimen. Next slide, please. Herpes simplex viral disease. This is the very common, most common viral infection along with the viral wart. The herpes simplex and the warts are the most common viral dermatological conditions. This condition is also found in the non-HIV patients, but in HIV cases, the severity will be more and the duration will be more. Generally, these infections are self-limiting and the lesions resolve within 2 to 3 weeks. But if the lesions doesn't resolve within 2 to 3 weeks, then one should suspect HIV infection. So in patients with HIV, this type of the infections persist more than the lesions in the non-HIV cases. There are mainly two types of herpes infection, simplex infection, that is HSV1 and HSV2, which are commonly infect skin. HSV1 mainly infect the oral mucosa, lips, and HSV2 mainly infect the genital mucosa. More than 95% of homosexual men with AIDS have a history of HSV infection. It is the very most common, I think, viral infection found in the HIV infection. HSV shedding occurs more frequently than when the CD4 cell count is less than 2 cells per cubic millimeter. It is the significant cause of proctitis in men with HIV infection who have sex with men. So if any person is having rectal pain or rectal bleeding, so besides gonococcal and the chlamydial infection, if you give treatment for gonococcal and chlamydial and there is no response, then do suspect herpetic proctitis. So herpetic proctitis is also very common, especially in those who have sex with men. The manifestation of non-mucosal HSV infections may be found in HIV positive patients, that is HSV keratitis, HSV encephalitis, HSV hepatitis, herpetic vitiligo, are like those observed in HIV seronegative individuals. Next. Herpes simplex virus disease recurrence is the rule in these cases. Primary infections. In primary infections, there will be most severe form of the herpes simplex disease. Later on, when it reoccurs, the severity will be less. So primary infection, host acquired infection for the first time, and the severity will be the most severe cases. Latent infection, the virus genome remains in the host cells in inactive form throughout the life. So if any patient acquire HSV infections, he has to be infected lifelong, and he will have recurrent infection with herpes simplex virus. Reactivation, recurrence is the rule. Reactivation occurs when the host immune system is impaired or any other stress to the body, any stress of the body, like emotional stress, physical stress, excessive sunlight exposure, even after the fever, any type of fever, there will be recurrence of the herpes simplex infection. Next slide. Clinical manifestation. Some HSV1 infections involve the orolabial region, while the HSV2 infection involve the genital region, genital mucosa. In these cases, in both type of cases, initially we'll found the vesicle formation, multiple fluid-filled, clear fluid-filled lesions, which rapidly progress to erosions and ulceration formations in both the conditions. So first, patient will develop vesicles, itchy, sometimes mildly pruritic, clear fluid lesions, which get ulcerated in 24 hours. Within 24 hours or sometimes 48 hours, these vesicles get ulcerated. So most of the time we see multiple superficial ulceration in orolabial herpes or genital herpes. But in some cases where CD4 cell count is less than 50, in that case, we found patient may have deep ulcers, which are not characteristics of herpes. We call it a chronic herpetic ulcer, and that ulcer persists for more than 1 month. So in herpetic lesions, we can find the deeper ulcer also. And in those cases, CD4 count will be very, very less, most probably less than 50 cells per microliter. If there is all the conditions, all the self-limiting, orolabial herpes resolves within 1 to 2 weeks, while genital herpes resolves within 2 to 3 weeks. But if patient is HIV positive, the total duration may be extended up to 4 weeks or more than 4 weeks. Next slide. We can see here the children having the multiple fluid-filled lesions. This seem to be the primary infections. Primary infection is the most severe form of the herpes infection. So this is seem to be the primary. You can see here the multiple fluid-filled lesions. Some pustules may be seen, grouped lesions. These multiple vesicles get coalesced to form the large blisters here. So this is the very common presentation of the orolabial infection. Here we can see the genital herpes, grouped superficial vesicles found on the shaft of the penis, and these vesicles will rupture within 24 to 48 hours. So this is the most common presentation of the genital herpes. Next slide, please. Diagnosis of herpes simplex infection is very easy. It is sometimes, but sometimes it may be difficult when there is mixed infections. Like suppose patient is having genital herpes and the primary chancre of syphilis as chancroid, then one should have to go further confirmation of the diagnosis, and the diagnosis is confirmed by PCR and viral culture, which is not available at many centers. This is also not available even at our institute. So this is very difficult for us to confirm the diagnosis. The most of the cases we diagnose the cases just simply by the clinical feature and history of recurrence. History of recurrence is very common and very common points in the history. Okay, management duration of treatment is about 7 days. In both the condition, 7 days treatment is sufficient, but sometimes patient may require treatment for 10 to 14 days. And the most commonly prescribed drug is acyclovir, which is given 400 milligram 3 times a day. And in children, 20 milligram per kg body weight, up to a maximum of 400 milligram per dose may be given by mouth 4 times a day for 7 to 10 days. Sometimes we can give valacyclovir 1 gram orally twice a day, again for 7 to 10 days. And the management is also same oral as far as the genital lesion is concerned. But sometimes you may have the very severe mucocutaneous herpes simplex virus infection. In this condition, we have to give acyclovir intravenously. And the dose of acyclovir intravenous dose is 5 mg per kg body weight, 8 hourly. And in children less than 12 years of age, beyond neonatal period, 10 mg per kg body weight. So in children, dose is just double, 10 mg per kg body weight, up to a maximum of 15 milligram per kg body weight per dose, IV 8 hourly for 21 days. After lesions begin to regress, change to oral therapy as above and continue until healed. So in severe form of mucocutaneous herpes simplex infections, intravenous acyclovir is needed. Next slide. Sometimes, especially in the patients of HIV positive, there are some reports of acyclovir resistance. In that case, foscarnet is given. Here is the chart for the treatment in neonates and the children living with HIV. Its dose of acyclovir in neonatal CNS disease. High doses is given 20 milligram per kg per dose, IV 3 times a day for 21 days is given. Neonatal skin, eye or oral disease, we give 20 milligram per kg per dose, IV TDS for 14 days. The duration is reduced in cutaneous and eye involvement in respect to the CNS disease. Outside neonatal period, CNS disease, we can use 10 mg per kg per dose, IV TDS for 14 days. In severe gingivitis, IV treatment is given, while in mild gingivitis, oral treatment may be sufficient. But if there is chances of resistance, if patient didn't respond with the acyclovir, then do suspect for the acyclovir resistance. Although there are very, I don't think most of the centers have any facility for the finding out the acyclovir resistance. But if lesions are not cleared with the acyclovir, then in patient HIV positive, then we should think about the acyclovir resistance, and we can give foscarnet 40 mg per kg body weight 8 hourly, or you can give 120 milligram per kg body weight. I've been 2 to 3 divided doses till the infection resolved. It usually takes 10 to 14 days. The foscarnet has to be given for 10 to 14 days. Next slide, please. Herpes zoster. Herpes zoster is caused by the same virus which causes varicella, and or another common name is chicken pox. It is caused by, it is a human herpes virus type 3. It occurs in 5 to 15% of the patient living with HIV. Courses of herpes zoster is also more prolonged with a high risk of scarring and post-herpetic neuralgia. Herpes zoster is also a common viral infection in non-HIV infection. But in HIV infection, there are some atypical presentation of herpes zoster. Herpes zoster usually involves single dermatome. But in some cases, in HIV patients, it can involve the multiple dermatome. Sometimes disseminated lesion of herpes zoster is found. Or rarely, some patient may have the recurrence of herpes zoster. While recurrence is not found in non-HIV patients. Recurrence, if there is a recurrence of herpes zoster, most probably patient is immunocompromised and one should rule out HIV. Clinical manifestation of herpes zoster is slightly different in this slide. Actually, herpes zoster is has only the single in a particular dermatome. The most common dermatome is the thorax, but it can involve the chest or abdomen, ophthalmic lesion, any part of the body. But most common it involve the thorax and the face. The most common site for involvement of the herpes zoster. Next, you can see here the most common site involvement of the trunk and the thorax, in which we can see the multiple fluid-filled vesicles and bully lesion, and these lesions will be very, very painful. The painful grooved vesicular lesions on erythematous base in a particular dermatome is nothing but herpes zoster. If there is anybody having this type of lesions, patient is a case of herpes zoster. Here you can see the healed region of ophthalmic zoster, herpes zoster ophthalmicus. You can see here the involvement of the eye. If you don't give treatment in time, the patient may become blind. So blindness may occur in this type of herpes zoster. Next slide, please. Clinical diagnosis is very distinct, but diagnostic of this is the viral culture and direct fluorescent antigen testing or PCR. There is no recommended prophylaxis, although there are some vaccines now available for prevention of herpes zoster. So now you can say we can prevent herpes zoster. There is a recent vaccine launched by the Glasgow also. So we can have the vaccine for the herpes zoster. Management is to 10 days, and the treatment is acyclovir 800 mg 5 times a day or valacyclovir. Generally, we still have the confidence on the acyclovir because it has got the very long safety profile for a many decades. So we still prefer acyclovir 800 mg 5 times a day for 7 to 10 days. But there are some other options also which are also effective. That is valacyclovir. If you are giving valacyclovir, then 1000 mg 3 times a day, or if you are using the famciclovir 500 mg oral 3 times a day, is the treatment of herpes zoster. Next slide, please. Management of herpes zoster ophthalmicus. If a patient is having the herpes zoster lesion around the eyes, which involves the eye also, in that case, we have to give systemic antiviral treatment in the form of acyclovir. Along with the antiviral treatment, one should also give short course of systemic steroid. This is very important, which is not mentioned in the slides, but we use, and that is very effective, because if you give only acyclovir, we cannot sometimes we cannot save the eyes due to very inflammatory condition. So we have to give systemic steroid just for 5 days, 40 mg of prednisolone, just for 5 days. And there are reports that if you use systemic corticosteroid in herpes zoster ophthalmicus, any other herpes zoster, then there is no any chances of increase in viral replication of varicella zoster virus or even the HIV. The short course of 5 days course of prednisolone should be given in every case of herpes zoster ophthalmicus, just to prevent the blindness. Sometimes patient may have extensive cutaneous lesion or visceral involvement. We call it as the disseminated herpes zoster. So if there is disseminated herpes zoster or visceral involvement, then patient require injectable acyclovir, and the dose is 10 mg acyclovir IP per kg every 8 hours until clinical improvement is evident. Switch to oral therapy. When formation of new lesions has ceased and signs and symptoms of bacillus zoster virus infections are improving. Next slide, please. We have already discussed, I think, management of varicella in the children in the HIV with HIV. Moderate severe disease, acyclovir is given 10 milligram per kg per dose IV every 8 hours for 7 days. In mild disease, acyclovir 20 milligram orally is given 20 milligram per kg per dose every 6 hours for 7 days. Acyclovir is the treatment of choice in the children. But in the case of acyclovir resistance, foscarnet is used, and the total dose is 120 milligram per kg per day, which is given as in 3 divided doses. That is 40 milligram per kg per day, 3 doses for 7 days. Sometimes it may be given for 10 days also. Next slide, please. Molluscum contagiosum. Molluscum contagiosum is also a very common viral infection which is found mainly in the children. It is the very common viral infection found in the children. But in HIV positive patients, adult can also have the molluscum contagiosum lesions and face. Generally, we see the smaller lesions. Molluscum contagiosum have the lesions in few millimeter, 1 to 5 millimeter, 10 maximum 10 millimeter. But if size of the molluscum contagiosum lesion is more than 1.5 centimeter, that is more than 15 millimeter, we call it giant molluscum contagiosum. So giant molluscum contagiosum on the face of an adult person is nothing but a case of HIV infection. So this is also very highly indicative viral infection, which is very specifically found in the HIV/AIDS. It is caused by pox virus, DNA pox virus, and it spreads through skin to skin contact, especially during sexual activity that involves the friction, the skin irritation. Lesions are very small, pearly, skin colored, pearly, dome shaped, because there is found the slight depression in the center, and the size usually is 2 to 10 millimeter in diameter. But in patients with the HIV, the size may be very large in size, even the more than 15 millimeter, 20 millimeter size of lesion is also found in the face, which are characteristic of HIV/AIDS, and tend to proliferate. Next slide, please. Here we can see the larger lesions. These are the giant molluscum contagiosum lesions with the central umbilication. You can see here the umbilication in every lesion, whether it is small or large. So umbilication is very characteristically found in the molluscum contagiosum. These lesions will be asymptomatic. There will be no any itching or pain, and all the lesions will disappear after starting ART. So our approach should be in this type of cases should be very conservative. These lesions will be resolved after initiating ART. Next slide, please. So treatment is not needed in most of the cases, but there is due to the cosmetic disfigurement, we give treatment in the form of, we have to destroy. There is no any specific treatment of the molluscum contagiosum. We have to destroy the lesions by cryotherapy using liquid nitrogen or chemical cautery, or extracting the lesions, or topical gel. There are some topical gels are also available for the treatment: podophyllum, trichloroacetic acid, cantharidin, tretinoin, tincture of iodine. But it is better to leave. We in generally treat trichloroacetic acid. 30% TCA is applied, and the patient got some relief, and wait for the improvement of the immune status, because all the lesions disappear with the ART after starting 2 to 3 months of starting, sometimes 6 months of starting ART. So in fact, this treatment, this condition is not required any treatment. It will resolve with ART. Next slide. Oral hairy leukoplakia is also very highly specific to HIV/AIDS. It is very rare in non-HIV cases. So this is one of the highly indicative for HIV/AIDS. It is caused by Epstein-Barr virus, which is also human herpes virus 4, and it occurs almost exclusively in the people with immunosuppression. More than 25% of the patients develop oral hairy leukoplakia at some point, and it can occur at any level, but is more common when the CD4 cell count falls below 200 cells per cubic millimeter. Possibly one of the first sign of development of AIDS is oral hairy leukoplakia. Again, this resolves with the ART. There is no any specific treatment. Next. Clinical presentation is very characteristic. We'll find the white striation. We also call it the vertically ripped along the lateral margin of the tongue. The lateral margin of the tongue is the most common sites, and the lesions are asymptomatic. There will be no any problem with these lesions, just for the cosmetic problem. Can be saggy in appearance and may contain several ridges. It may resemble oral candidiasis, but it does not come off on scraping. Like in oral candidiasis, if you scrape the lesions with glass slides, it will be scraped out, leaving the raw area beneath it. But these lesions cannot be scraped out. Usually asymptomatic and is usually discovered during a routine clinical examination. We have seen some patients who directly came to our OPD with only complaint with oral hairy leukoplakia without any complaint of HIV/AIDS. So we have some patients of this condition on patient consulted to us with no any other signs symptoms of HIV/AIDS. Next slide, please. We can see here these are the whitish plaque vertically ripped on the lateral border of the tongue. In some patient may have the unilateral involvement, but sometimes bilateral involvement of the lateral border of the tongue is there. You can see also that this the plaque, leukoplakic plaque, whitish to pigmented plaque on the lateral border of the tongue. Next. Diagnosis, mainly clinical inspection. Scrap test is very useful because it cannot be scraped. Diagnosis confirmed if Epstein-Barr virus is identified in oral lesions by electron microscopy, but we don't have to go for this electron microscopy because this is very benign condition. Usually does not require any treatment. Tetinoin and podophyllin resins can be applied directly with the passage. Leukinidone cryotherapy or surgery or other alternative, but don't give any treatment. It will resolve with the ART. Next slide. Now, after the infectious condition, we'll discuss inflammatory conditions. Next slide. Xerosis and ichthyosis. Xerosis means dryness. Dryness. Ichthyosis means fish-like skin. So this condition, xerosis, is very, very common. I think the most common inflammatory condition found in HIV/AIDS. So dryness of the skin with pruritus, and this dryness may lead to pruritus. It's very, very common, especially in advanced stage of HIV infection. And the most prominent will be on the upper limbs and the lower limbs. Upper limbs and lower limbs are the most commonly affected, although sometimes whole body is affected with xerosis and ichthyosis. And the treatment is just the application of moisturizers. Sometimes if there is pruritus, itching, then we can use the mild topical corticosteroids in the form of hydrocortisone or triamcinolone for dermatitis. But in this condition, ask the patient not to use soap frequently. There should be infrequent application of soap, moisturizing soap should be used, and frequent application moisturizer should be done. Next. Seborrheic dermatitis. Seborrheic dermatitis is supposed to be the first mucocutaneous manifestation after the xanthum. First mucocutaneous manifestation, seborrheic dermatitis. Seborrheic dermatitis is very common dermatological condition which occurs mainly in the winter seasons, which is commonly known as dandruff. Dandruff is another common name of the seborrheic dermatitis. But in patients with HIV, severity will be more. Generally, in non-HIV patients, scalp is mainly involved and the central part of the face is involved. But in HIV patients, whole trunk may be involved, and the severity will be more, and there will be more erythema. So severity and the extent is the important point further this condition to be found in the HIV positive patient. Generally, a mild eruption usually affecting the scalp and central area of the face, occasionally chest, mid part of the chest, particularly in individual with a lot of chest hair, and the axilla and groin. One of the most common inflammatory dermatosis observed in children living with HIV, that is 83%. It is poorly defined faint pink patches with mild to profuse, fine, loose, waxy scale, greasy scales. We call it greasy scale. In children living with HIV, it may present as erythematous, scaly patches within overlying greasy scale on the scalp. Eyebrow is also very common side. Perinasal, chest, and the periauricular area is also involved. Sometimes we may found the back, interscapular area, axilla, groin, and pubic area. These are the common sites for the seborrheic dermatitis. And the treatment is mild topical corticosteroids, and cold tar shampoos are preferred. Tars, I don't know how this is mentioned. Tar shampoo, ketoconazole shampoo is used for the seborrheic dermatitis. Some patient may require antifungal also. So generally, we give mild topical corticosteroids along with the topical antifungal agents. And ketoconazole shampoo is the most preferred and should be used for the treatment of seborrheic dermatitis. Next slide. After that, then hepatic condition will discuss cutaneous malignancy. Kaposi sarcoma will be covered in another session. So we'll discuss mainly the non-Hodgkin's lymphoma. Next slide, please. Non-Hodgkin's lymphoma prevalence is up to 4.3% higher than that in the general population. It's the most common type of cancer reported in Indian patients with HIV. High level of the lactate dehydrogenase and advanced systemic disease in 80% of the cases. Manifestation depend on the site involved. Mainly we found the nodular lesions on the chest. Some lesions may look like erythematous vascular. In patient HIV, it has a highly invasive behavior due to disease progression, and treatment is chemotherapy and CHOP treatment. Next slide. These are the lesion of the non-Hodgkin's lymphoma. You can see here the large nodular lesion on the abdomen and the interior folds of the axilla. You can see here the nodular erythematous nodule. So these are the very common presentation of non-Hodgkin's lymphoma, cutaneous non-Hodgkin's lymphoma. Next slide. In male, PLHIV 38%, in female 16%, and risk in male is slightly higher, 17 times, while the risk in the female is 10 times. Next slide. There are some miscellaneous conditions which are associated with HIV infections. Among these, the drug reactions. Drug reaction is very important. Sometimes we see the patient first time in our hospital in the form of severe type of the drug reaction like Stevens-Johnson syndrome or toxic epidermal necrolysis. So we recommend HIV testing in all type of severe drug reactions, whether it is Stevens-Johnson syndrome, toxic epidermal necrolysis, or DIHS, DRESS syndrome, induced hypersensitivity syndrome. So drug reactions are very, very common. In fact, 100 times more, incidence is more, just double in comparison to the non-HIV patients. The drug reaction is very, very common, especially the co-trimethyl drug, bacterium-based drug causes very severe drug reactions. So we can have the spectrum of the mucocutaneous manifestation in the drug reactions. It may be very mild maculopapular eruptions, or may have the very severe reactions in the form of erythema multiforme, Stevens-Johnson syndrome, and the toxic epidermal necrolysis. The incidence of drug reaction is very, very common in the HIV positive patients. Next slide, please. Next, please. Most reactions occur in the second week of therapy and are typically maculopapular and morphiform rash. Use of systemic corticosteroids in treating PCP has substantially reduced the rate of the drug reaction from cotrimoxazole. So when before the systemic corticosteroid, there is very high chances of the drug reaction with the TMP and SMSA, cotrimoxazole. Other drug-induced hypersensitivity reactions like arterial reactions, exfoliative dermatitis, erythroderma, fixed eruption, multiforming, SJS, Stevens-Johnson syndrome is missing here. Toxic epidermal necrolysis is very, very common in the HIV positive patient. Next. Another miscellaneous condition is the pruritic papular eruption. This is very commonly found in the poor country like our. It is uncommon or rare in the developed country like American, European country, because this is mainly precipitated caused by the insect bite. So the lesions will be mainly on the exposed part of the body, like the legs and the hands, feet, and the face. So these are the most common sites. Lower limb, upper limb, face are the which are the exposed to the mosquito bites, insect bite, are the mainly involved in this condition. And this condition is very, very pruritic. There will be very severe itching, and patient develop the folliculitis, bacterial infections due to the scratching. So this is very itchy condition which is found in the, and very itchy common condition found in the patient with HIV. Next. Prevalence of this condition is 11% to 46%. I think prevalence is very high in our setup. We have seen in every second patient is having pruritic papular eruptions. Pruritic papular eruptions can be first marker of HIV infection because it occurs mainly when the CD4 count is falls below 200. It presents as the chronic bilateral symmetrical pruritic papules and sterile pustules on the extremities. Extremities is far more common than the trunk. The differential diagnosis is the follicular, non-follicular pruritic eruptions, including scabies, insect bites, prurigo nodularis, and edematous conditions. And the treatment, topical steroid with topical antibiotic combination should be used, and the oral antihistaminic. In these cases, we use sedative antihistaminic. Potent and sedative antihistaminics are required for this condition because non-sedative antihistaminic will not work. Use antibiotic in if there is the folliculitis or secondary bacterial infections. Next slide, please. This is the acute HIV in exanthem and enanthem. And this condition is found after 2 to 4 weeks of acquiring HIV infections. And this is the maculopapular rash found on the, especially the upper part of the body. Frequency of the rash in acute HIV infection can be 50%. It is found in 2/3 of the cases. Rash may be xanthematous or perogia-like over the upper trunk, proximal limb, may involve the palms and soles. Sometimes face may be involved. We have seen the case of face involvement. There are associated systemic features like fever, malaise, myalgia, arthralgia, pharyngitis. Along with this, patient may have the septic meningitis, and some GI symptoms like nausea, vomiting, and diarrhea is also found along with this exanthem. In associated enanthem of the oral erythema, sometimes you may find the oral lesions also in acute HIV conditions in the form of erythema or palatal erosion. Sometimes oral ulcer may be found. Next slide, please. Thank you.
Thank you so much, sir. Any questions from the participants? Please feel free to unmute your mic. You can also type in the chat box. Sir, I don't think there are any questions. Can we go ahead with the feedback form?
Any question?
Yes.
I have one question, sir.
Yes, sir.
Yeah, please.
Regarding the
Not audible, sir.
Syphilis case after treatment, you said that RPR to be syphilis follow-up.
Yeah.
Hello?
Yeah, hi, yes, I'm ready.
Yes. Yeah. You said that RPR is to be done after 6 months. If it
Actually,
turns out to
it
be
is-
positive.
Actually, it should be done after 3 months, every 3 months in HIV cases. and 6 months
Yes.
in non-HIV cases, but in slide it is mentioned 6 months.
Okay. And
in
if it turns out to
cases,
be,
in HIV cases, RPR test should be repeated every 3 months.
okay,
In
sir.
non-HIV cases, it should be repeated after 6 months.
Okay, sir. And if it is positive, I mean, my question is that what we have to do if it is positive after 3 months, 6 months?
No, if it is positive, actually we have to find out the titer. We have to look for the titer. Titer is important. Positive is not important because
Okay.
it will take about 12 months. Some cases 6 to 12 months. Yes, some in secondary syphilis it may take 24, sometimes 2 years, 24 months to disappear to be negative. But if titer should be less, titer will be declined. After giving injection, titer should decline
Okay,
by
sir.
1/4. Suppose titer is 1:32. So it should be,
Yes, sir.
it should be declined after 3 months. So you can say it will be 1:16, 1:8, 1:4. This way it will decline.
Thank you, sir. Thank you. Thank you.
Most welcome.
Any more questions? Can someone confirm if this feedback form is visible on the screen? Yes, it's visible.
Ma'am, visible.
Ji, thank you, sir. Thank you.
Okay.
Any other question?
So there are no questions.
Okay.
Thank you so much, sir, for facilitating this session.
My
Thank you.
pleasure. Thank you. Thank you for inviting.
Thank you to all the participants for patient listening. We'll conclude the session now.
Okay, thank you.